I'm ready. So I'll start, okay? So for the first aliquot, we have a 64-year-old female who presents with shortness of breath, generalized weakness, and a non-productive cough without hemoptysis or other associated symptoms. The patient reports poor oral intake for the past 2 months. The shortness of breath has progressively worsened, limiting her ability to ambulate. So, approximately 2 months ago, she was treated with short course of steroids for shoulder and hip pain, which was labeled as polymyalgia rheumatica. That's all.
Ravi, do you
Great.
want me to take this first one?
Yeah, if you want to, yeah, go ahead.
Okay, so thanks, Vinny. Pretty rich first aliquot there. So I think Vinny did a good job of like kind of giving us a hint of what may the background be here. But when I see shortness of breath, weakness, cough, and then also 2 months, this is something that's getting progressively worse in a subacute time frame. And I also find it interesting that, when you give, so one of the diagnostic criteria for PMR is like the rapid resolution of muscle stiffness and weakness with steroids. So it's curious to know, I would be curious to know if the weakness that she had when she got this presumed diagnosis of PMR, if it got better after the steroids. Because if it did, then it's made it more suggestive of PMR. But I also find it interesting that Vinny said that it is a short course of steroids for PMR, because PMR is not treated short course. It's usually a prolonged, like 12-month duration. And a lot of patients end up having relapses with their PMR too. So they may need longer than the 12-month stretch. So I find that interesting. So it's either PMR didn't get properly treated because there was a short course, and now she's having the weakness from there. And then how can we tie in the cough and the shortness of breath? Well, PMR is pretty closely associated with GCA, and is there a vasculitis component going in from there as well? So that's one thing that vasculitis with the association with like ILD. So that's what I'm currently thinking about. But common things being common, I would obviously work her up for pneumonia and see if there's any evidence on a chest X-ray that we can see that this could just be pneumonia. But for 2 months, I'm leaning towards something more of a subacute process. Ravi, what do you think?
Oh, I think you're off to the races with what to prioritize here. I like both of us sort of honed in on the shortness of breath, and there appears to be probably something that can explain everything. I guess if you're not able to breathe, you get weak, or is the other thing I was thinking was the weakness affecting the breathing, but then also you have cough. So then I think the environment that we sort of have to work within is probably the environment of the lungs, cough, shortness of breath. And again, cough has its own sort of different causes, but we're dealing with upper respiratory, lower respiratory problems, probably, possibly, but cough can also be non-specific. But you have many different causes, such as asthma, reactive airway disease, and so on. What was interesting, the steroids did not resolve this. And just by introducing steroids there, I was wondering what, a lot of times, like Vinny talked about this other case that we had where there was an intervention and the intervention caused the adverse event. So here is an intervention. If we take this, for example, you take the steroids, what can steroids do to the body? It can do many different things, hyperglycemia, Cushingoid features, and so on, but it can also introduce its own set of muscle involvement or conditions where there's muscle involvement, like steroid-induced myopathy. So that's something I think I would highlight at this point. The PMR is interesting, right? So the PMR, usually I used to think about weakness, but usually you get shoulder and hip girdle pain. So you're not weak, you actually have pain which limits your ability to move, and then you're weak. because it's just very painful to move. So Vinicius did not mention there's pain. So there's I'm saying PM&R, but PMR is probably a diagnosis that was rapidly maced or hastily made without any of the background, like the workup, like what is there associated GCA? What are the inflammatory markers and so on? But I'm very suspicious that this is probably not the right diagnosis. And we're dealing with a patient that is being treated over 2 months and has not been worked up properly or appropriately. And I like that you mentioned, okay, if we don't know what is going on, let's do some diagnostic tests to push or move the needle forward in trying to figure out what we're dealing with, like you said, pneumonia, maybe ILD or something like that. So I would kind of start here, but then I would also highlight or put on the back burner steroids. By introducing steroids early without really knowing the diagnosis, you could have actually made the situation worse. Anything else?
No, that was excellent. I just wanted to clarify. I'm pretty sure I said 12 months, but in case I said 12 weeks, the steroid course is for 12 months for PMR. Just wanted to correct myself if I said weeks. And then the other thing is, I'm glad you brought up the classification of PMR. And for those because we have all sorts of learners online here today. The diagnostic criteria for PMR, to be honest with you, is a clinical diagnosis in addition with lab findings, and that is an elevated ESR and CRP. Typically, ESR is more elevated than the CRP, and you have a normal CK. And that's how you differentiate it between like a myositis, because myositis will have elevated CK. Now, if you have normal ESR CRP with an elevated CK, then you're looking at your statin-induced myopathy. However, I'm going to put an asterisk on that and say you can have inflammatory versions of statin-induced myositis, especially with the anti-HMG-CoA reductase antibody. With that, I'll pass it over to Vinicius for the next aliquot.
Okay, so amazing discussion for just the first aliquot. And I have 5 aliquots. The final one will reveal the diagnosis. And for the second one, the review of systems is positive for arthralgia affecting the knees and hands since 2 months ago. The patient has no past medical history that is significant, no current medications, and no surgical history. She is from the Midwest, specifically from the rural part of Missouri, with no recent travel, some hiking in the area, and no non-animal exposures. Vital signs are stable. Oh, okay. So yeah, I can go to the physical examination, and that is the kind of in the middle of the aliquot. But if you guys want to comment something.
Yeah, let's stop there. This is something very interesting with the review system. So you have arthralgias, knee and hands symmetrical, but wait a minute. We were talking about PMR, and synovitis in the hands is usually not common. So does this immediately exclude PMR? I keep saying PMR, but PMR, I don't know, but it puts it lower down in my list of differential diagnosis. So what kind of things should we think about with knees and hands that are symmetrical? Rheumatoid arthritis is something that is symmetrical. What else can be symmetrical? Lupus is symmetrical. So those kind of conditions, if we're talking about autoimmune disorders, I think those would be things to consider in this case. But the Midwest Missouri, now you pose an interesting challenge. Could there be something of a tick-borne etiology that we haven't like explored yet? I'm not sure, but something to put on your radar screen. But what do you think at this point, Jasdeep? But still, the steroids poses an interesting sort of clinical conundrum. Like, is this all due to steroids? Although arthralgias, usually you will have muscular pain maybe, but not arthralgias. And steroids should take care of any inflammation of the knee or the hands. It should help with that. But you have this in spite of the steroids.
Yeah, nothing much to add. More of a clarification from Vinny. Vinny, how long did the patient, when you say short course, how long was this? Was this a week, 2 weeks, or months?
Yeah, kind of. We don't have like specifically you mean to the steroid that she received 2 months ago, yeah?
Yeah,
You're
so what, yeah,
referring, yeah.
correct.
Yeah, what was kind of two maybe 1 2 weeks, but not like was not a month or nothing like that.
Okay, so just want to make sure I heard this correctly, that it seems like it was maybe
Yeah,
1 to 2 weeks of steroids, correct?
yeah, that's it. Mhm.
And do you remember the dose of it?
No, actually, I don't remember. I don't know if it was a high dose. Sorry.
That's okay. So the reason why I'm asking is like 1 to 2 weeks. I don't have a strong suspicion that this could lead to, steroid-induced myopathy or anything like that. I would expect it to be longer, but I guess it's still possible. But Robbie, I have nothing else to add. I do 100% agree with you that the involvement of the hands is atypical for PMR. Something that I have seen is something called Asia, which is the systemic inflammation of adjuvants, which can happen after vaccines, typically COVID vaccine, not to put more propaganda out there, but that can present like PMR, but can actually involve the hands as too. And I've actually seen this case in residency. But I have nothing else to add. I would love to get more information from Vinny.
Okay, perfect. So, for the physical examination, vitals are stable except for an oxygen saturation of 90% on room air. Physical examination reveals a thin, very uncomfortable woman with severe dyspnea at rest and increased work of breathing. Auscultation reveals diffuse rhonchi and crackles. Also, it was a very dirty auscultation throughout me. And cardiac, abdominal, neurological, and extremity examination are normal. So basically, the physical examination, the patient was very uncomfortable. So that's the poor history, and we don't have like she couldn't give more information about the past medical history and other things. Yeah.
So, Jas, you want to take a stab at this first?
Sure. Um, so it seems like vitals were not that impressive. She was thin appearing. So I feel like the thin appearing would be concerning for me in the sense that this may be a cachectic process that's been going on. And is it really the past 2 months, or has this been longer than the 2 month time frame? The dyspnea at rest is concerning for me. And I would basically have a close eye on this patient, even though that she's satting well in room air. I would basically have a low threshold of kind of like moving her to an area with like a step down unit, or just kind of an area where there's better monitoring, and may just, because that's the one thing I would be concerned for. Um, with the weakness and the dyspnea rest, is this weakness ascending that may involve the diaphragm? So that's where my concern is coming from, because in those patients, then I would be concerned that I need to have to protect their airways. But other than that, Robbie, I don't have much else to add from the physical exam. The thin appearing patient, if this is like a change, would be make me concerned for a cachectic process.
Yeah, absolutely. Just sort of echoing or piggybacking off this thin process we did have in the first aliquot, the mention of weight loss. So there's major inflammation when you deal with weight loss. Is it due to, and I love when our CPS members go through this and we use the same sort of schema, like is it poor access to food and so on, or is it an internal process? Is it outside, external process or internal process? Is it a digestive process or a hypermetabolic process, of which one of which is inflammation? So this patient, I think from the get-go, is inflamed. There's joints, there's lung. And I love how you thought about the lung. We started, or you honed in on the diaphragm being one component. But if I start thinking or breaking it down to the essentials, we have this joint. Oh, so we have joints, we have lungs, and then you start thinking about what can affect both of these areas. So a number of us has talked about maybe ILD with joint involvement, and still I don't know about the joints. Is there synovitis or is there just pain in the joints? So right now there looks like there's pain in the joints, but if we start thinking about joint involvement and lung involvement, we talked about symmetrical processes. So rheumatoid arthritis comes into play, lupus comes into play, scleroderma comes into play, and then sarcoidosis could be one too. And then I think dermatomyositis could also, you could plug that in there, although we're not getting any skin involvement. So are we sort of going to consider that domain? I don't know. Or is this knee and hand involvement just pain or inflammation? Is the inflammation emanating from the lungs? Again, this patient has major lung sounds, so the pathology is in the lungs. The SpO2 is not terrible, but it's the low range of normal. But this, I think the poem, did they say within normal limits? So, oh, was there, I was hearing Ronchi and stuff. Vinicius, could you correct me? Was there lung sounds?
Yeah, so it was a very like rich and lung sounds. So there crackles and wheezes and very diffuse. Yeah.
Okay. So the crackles and wheezes in diffuse regions of the lungs means the whole lung has pathology. Wheezing would be, so what does wheezing mean? The bronchi, or if you start with the anatomical lung tree, so upper respiratory tract, you'd have stridor. Bronchi, you will have major wheezing, such as like asthma and so on. Bronchioles could be any number of things. They could be bronchoconstriction, they could be mucus impacting that, they could be inflammation, they could be purulence, they could be any number of things. The crackles would be alveolar pathology. So what's going on in the alveolus? Could there be water that is lining the alveolus and I guess impacting the surface tension? You got surfactant on the outside, water in the on the inside, and if the forces are in or increased in the on the side of the water, you may get atelectasis and collapse, and then you may get, when you breathe, you pop open those airways or the alveoli and you get crackles. Could it be pus pneumonia again, revisiting what Jas said? So purulence in the alveoli, again, you would get crackles as the alveoli open up when you take a deep inspiratory effort. Could it be dry sort of fibrosis would also give you crackles? So there's all these abnormal lung sounds, and I think that should help us to focus in on the lungs. And that could be what I can't say it's the pivot point, but is probably a big ticket item to get us to the diagnosis. I guess imaging is probably what I would do next if I was managing this patient. What do you think, Jess?
Yeah, no, I agree. Imaging is I would say if I had to guess, I would say X-ray would not may show like no acute disease in the chest, which basically means like there's no consolidations or effusions. And then the CT showing ground glass opacities or NSIP, especially if we're thinking with this whole PMR type of autoinflammatory, autoimmune type of process. But one thing I came to my mind, I just want to preface, it doesn't apply to this patient, at least not yet. But if this patient was having these symptoms for like a year with the thin female with cough and shortness of breath, decreased PO intake is Lady Windermere syndrome, but it doesn't seem like it's too acute for that to be a possibility. But I agree with everything else you said. I think the labs would be telling to see if there's any gross or abnormalities, but I would be very hard pressed not to get a CT scan in real life. Vinny, back to you.
Okay, perfect. So for the third aliquot, we have laboratory results, white blood cell count of 16 with neutrophilic predominance, hemoglobin of 8.8, hematocrit of 27, platelets of 800, okay, MCV of 76, RDW of 15, and sodium of 121, potassium 4.6, chloride of 82, the CO2 of 24, anion gap of 15, BUN of 70, creatinine of 5.47. So creatinine of 5.47. And glucose of 167 and calcium of 8.2. If you want, I can proceed with some more labs.
I think, yeah, we have time to stop here. 6:22 we can discuss here. But there's a lot of remarkability in the labs now. If I just start, I guess I'll start with the WBC. If you want to weigh in on the chemistry, which also has a great deal of abnormality here. But with the white count of 16, I mean, it could be any number of things. What would be if I would step back and say, okay, does this white count really help us? The immediate reflexive response would be this could be an infection. However, there are many other causes of leukocytosis in a brand new patient being admitted to the hospital. So usually number one, number two, number three, white cell count. It could be a marker of infection. Also, you need to get a differential to see what exactly is causing the elevation in the white cell count. Eosinophilia, it could, if there's lymphocytosis, we could be dealing with some other abnormality. But here, you said the neutrophils elevated, sorry, and that means there's some sort of pyogenic infection. And as we stated, or Jas stated in the first aliquot, pneumonia would be high on our radar screen. However, other causes of white cell count elevation, steroids, right? The patient was on steroids. Sometimes I forget it. I could discuss a patient and think about this, and then we look at the medication list, and it was steroids that was causing the white cell count. Although what's interesting, you can still diagnose an infection with steroid-induced leukocytosis. You usually have to look at the differential, look for Dolly bodies, and look for there's Dolly bodies, and I'm forgetting the other finding, but it'll come back to me. But you look at the differential, and you see these other cells, bands. Sorry, yeah, bands. It suddenly came back to me. I have to get back into after vacation mode, get back into clinical reasoning mode. So bandemia would also be a big clue if you have steroids on board and you're trying to utilize the WBC count to diagnose infection. But the patient is inflamed, the hemoglobin is low. So, and the MCV being low, I tend to think about or utilize the tails mnemonic. Not all microcytic anemia is going to be iron deficiency. You have thalassemia, you have anemia of chronic disease, you have iron deficiency, you have tails, lead toxicity, and sideroblastic anemia. So here, I doubt sideroblastic, lead. The patient's not young, pediatric case ingesting paint off the wall that's lead laden. So here, this likely is inflammation. And again, the patient is highly inflamed, is thin, has lost weight. But I can sort of glean from this, there is an infection, but what else can cause a white count? The steroids could be involved. Stress could cause this as well. Inflammation, necrosis. And yeah, I think pretty much that will be my differential for white cell count. Anything else? I guess you want to take the chemistry, Jas?
Yeah. To be honest, right now, I'm not gonna dive too much on the hyponatremia because the creatinine definitely takes my attention. I've been burnt before when I see a pretty steep rise in the serum creatinine thing, and thinking of like, oh, should I start sending all like intrinsic renal disease type of process, urine studies and etc., or even lab studies. But in this patient, when we have a history of oral intake for the last 2 months, we would definitely want to fluid bolus this patient and do a saline challenge to see if the creatinine downtrends, because I definitely think there is a multifactorial component to her AKI, with both prerenal and then maybe intrinsic, either secondary to ATN from prolonged pre-renal etiology, or with this whole arthritis issue with this presumed PMR diagnosis, which now seems less and less likely, could there's now be a intrinsic renal disease like a vasculitis? And that's concerning and interesting at the same time for this patient, because you have a patient that has a pulmonary presentation of her symptoms, and now she has a renal involvement, and you definitely want to rule out pulmonary renal syndromes. One thing I would want to mention is the platelets of 800,000. That's a pretty significant thrombocytosis. And in her case, given her age alone, I would want to say this is more reactive than it is clonal, especially with the white count being okay. We don't have any other symptoms for us to be concerned for poems, but basically with reactive, I would hone in on autoimmune processes, to be honest with you, because what thrombocytosis tells me is that this is at least a subacute to chronic inflammatory state. And if it is autoimmune, interestingly enough, most of the time they're seronegative. So I understand a lot of us are probably thinking of the ANCAs and all that kind of stuff, but using that pearl, I would be interested to see if this might be a dermatomyositis or a polymyositis that may be leading to a profound picture that may explain the lungs and the vasculitis in other places. So, or sorry, myositis in causing the generalized weakness. But yes, obviously the first things you want to rule out is ANCA vasculitis and the pulmonary renal syndromes. And then if this is still infection, remember, we don't want to focus too much on the zebras. I would say this is more of a subacute to infection, especially with the thrombocytosis. So for this AKI, I think it's always good to assess if this is pre-renal, post-renal, or intrinsic. I think this is multifactorial in the setting of intrinsic and pre-renal for someone who has not had a good PO intake. I would do a fluid challenge and see how her creatinine trends. And if it is intrinsic, it could be ATN, from decreased PO intake, underlying sepsis. And I would definitely want to send complement levels if the fluid bolus did not really do much. If the complements are low, then that raises my concern for like lupus, NPGN, and then I would also want to send out ANCAs, because then that can help us to see if this is GPA or NPA or eGPA. And then if the complements are normal, that would be interesting, because that tells us that this is less likely to be vascular, at least for the time being. But complements sometimes are not always completely reliable. Anything to modify there, Ravi?
Yeah, I think you're absolutely right. If any of you are on residency and training, you will see such patients. We see a lot coming in, and from the history, you can glean a lot of times if there's volume loss, there's weight loss, this patient is likely has a fluid deficit. So giving some fluid will actually probably get that creatinine down to a certain level, and then you may hit a level where beyond which you can't get it down, and then other pathologies may set in, ATN and so on. You have to start working up. The next thing I would do, at least, we don't have a urine, so we need to get a urine to further differentiate what kind of process. So if a specific gravity is greater than 1.02, this patient is concentrated. Again, it suggests this patient is dehydrated. If you see proteinuria, then you have to start thinking about all the different nephrotic syndromes. If you have hematuria, nephrotic syndrome comes into play. Just one thing interesting, the platelet, for some reason, it wasn't red, but I didn't pick up on it. But we talked about microcytic anemia. Iron deficiency anemia could increase that platelet count up to 800,000. So, when you have anemia, you have increase in erythropoietin, right? So what's a mimicker or a cousin of erythropoietin is thrombopoietin. So if you have a fully functioning liver, fully functioning kidney, erythropoietin increases, that will increase also the platelet count. But here we have kidney failure. So it's kind of odd. The platelets shouldn't elevate with microcytic or anemia. But what's also puzzling me is the anion gap here. So what was the bicarb? 24. So the bicarb's not low, not terribly low, but there's an anion gap of 15. So it's a little perturbed. I wonder if there's like if the anion gap is normal is 12, so add 3 to that, is the lactic acid elevated? Maybe that's contributing to it. Because usually when you have a acute kidney injury, you have anagma until you get to like end stage anuria, ATN, and then you can have hagma with all the stuff that doesn't get filtered out through the kidneys. So that I find a little confusing there, but let's see if there's a urine, and I think we could then move on from there. I like that. Initially, you were like, okay, initially I thought, oh, this is a pulmonary renal syndrome, but no, step back. Could this be pulmonary edema? Could this be a pneumonia sepsis with pre-renal ATN? So yeah, we were still early in this process. So let's see what Vinicius has in store for us.
Okay, perfect, amazing. So yeah, we have a protein creatinine ratio that is 1,422 with a 24-hour urine protein at 510. Urinalysis shows cloudy urine with 1 plus protein, 2 plus blood, and 3 plus leukocyte steroids. White blood cell count ranging from 11 to 20, and red blood cell count ranging from 6 to 10 in the presence of mucus. So besides, we have a immunology studies that reveals normal IgA and IgM, elevated IgG at 700, and complement levels normal, so C3 and C4 normal. The CRP elevated at 312, in the ESR at 134. And rheumatoid factor is positive and elevated, while ANA is negative. So I'll give you that, and after I'll go to the image.
Well, we got a urine and what the number of findings, or what a lot of findings that we have here is, but you want to take a stab at it, Jas, and I'll back you up on it.
Yeah, sounds good. I was just laughing at your reaction when Vinny shared the urine protein to creatinine ratio. I'm just quickly looking at the last one last time. Okay. So all right. So going back from the previous aliquot, I was saying how, given the thrombocytosis, I would wonder if this patient's serology would be negative and still have an autoimmune process. And so far, that theory is currently being held up because this urine study is consistent with glomerulonephritis. We have a lot of protein. The interesting part is +1 protein, which is so it's nephritic range. But the U spot is pretty significant. And then you have the WBCs, RBCs, and proteins. So this is glomerulonephritis and normal complements. So that makes us feel that lupus would be less likely. Sjogren's would be less likely. I think what Vinny was hinting at with the IgG levels, could this be IgG4 disease? IgG4 disease typically is very indolent. This patient, I would say, is progressing too fast for this to be IgG4 disease. And remember, I just want to preface that IgG4 disease can only be diagnosed on tissue diagnosis with storiform fibrosis and a ratio of plasma of IgG for plasma cells, but it does not present. It does not seem like it fits that illness script for me. And then C3GN can also do it, but it wouldn't explain the lung findings. So the other possibilities of normal complement would be basically post-immune. So that comes into your ANCA vasculitis. And with the other thing is with the rheumatoid factor positive being positive, I wonder if this could be a manifestation of RA. To be honest with you, I haven't seen RA present like this, where it kind of chews through the kidney in this glomerulonephritis type of pattern. However, the complication from RA, similar to hepatitis C, would be cryoglobulinemia, which can. But thing is, though, with cryoglobulinemia, you would have decreasing complements. So that's the thing that's kind of making me pause here. Do I really want to invest all my energy into one test? No, I would definitely repeat the complements again. Just yesterday, I saw a patient that had a normal leukocytosis and procalcitonin. I didn't feel like it lined up with his clinical picture. Repeated it the next day. Procal was 8. White count went up to like 20. So labs are just exactly that. They're a snapshot in time. So right now, I think this doesn't really, I think I would really want to get the ANCAs, and I would want to get a CT of the chest to see if there's ground glass opacities. Is there granulomatous disease? Is there some type of consolidation? Is there something we can biopsy, like lymph nodes, that may help us find a diagnosis? Because there's a good chance her serologies may come back negative, and we need tissue biopsy too, whether it's a kidney biopsy or something in the lung that we need to biopsy. Ravi, what are your thoughts?
Oh, you pretty much covered everything. Yeah, you dissected the renal labs here perfectly. Yeah, I like that you kind of like looked at the sodium. Okay, the sodium is a byproduct of everything that's happening here. It's not the primary process, so we do not have to go down that route trying to figure it out. If you have lung involvement, you could get SIDH, you could have these issues. Plus, you have the kidney involvement, and then fluid overload. If the patient, we haven't even quantitated how much urine output there is, but if the patient is oliguric, then volume overload could cause it. So we're not going to expend too much thought there. This protein crowning, yeah, my eyes lit up. I was like, oh, now there is a signal we can latch on to, and we can further explore what is at the center of gravity of this case. So you're right. You know what's interesting? The protein crowning ratio. So if it's like 3,000, there are things that can influence it. It's not a perfect test, but if it's 3,000, you're thinking, okay, there could be nephrotic syndrome, but we're in the nephritic range. But the other proteins that it could pick up could be light chains, heavy chains. Could we be dealing with a myeloma? Although that tends to attack the glomerulus, so we would have nephrotic syndrome in this case, but we don't have that picture. So that's something just to think about at this stage. But the patient, again, this CRP ESR is very elevated, and this backs up our thought of inflammation. And where's the inflammation? At the side of the kidney. Could it also involve the lung? I'm not sure, but let's see. Maybe there's a pneumonia. When you have renal injury, the patient is immunocompromised. The patient who was on steroids is immunocompromised, develop a secondary pneumonia, but the kidney is at the heart of the matter. So I definitely, like you had mentioned, the tests I would do. Did we get the C3? Yeah, C3, C4 is normal. SPEP, UPEP. Get the ANCAs I'm very interested in. Yeah, we early on had thought about maybe there's a vasculitis, and there was a presumption of vasculitis early on. So yeah, I would wait for these tests. The nephrotic labs you tend to get in the workup, but at this point, I'm not. The anti-PLA2R and so on. I'm more interested in the ANCA labs, and I'll see if Vinicius has them for us, ready for us, I guess.
Yeah, okay. So I have one question. Just can you briefly repeat about the relation of the CRP and ESR, what you could expect about the relation when one is higher and the other one is not so high?
Yeah, so basically, I think every clinician is different. Some people don't like inflammatory testing. I in fact love sending out inflammatory markers. I obviously don't send it out for classic community-acquired pneumonia, because obviously they're going to be elevated. But in situations like this, it is so helpful, because in this patient, both the CRP and the ESR is high. However, I've seen the CRPs as high as like 500s. And then I've seen ESRs come off usually 134 ESR is pretty high. So this patient has both acute and chronic infection. So ESR is more correlated to a chronic inflammatory process, However, there are some studies that linking it to an autoimmune or malignant processes, whereas CRP is more for bacterial. However, that doesn't always pan out. You can have CRP elevation in autoimmune and malignant conditions. But I think in this case, given the fact that CRP and ESR are both pretty significantly elevated, what this tells me is this is probably a chronic or subacute underlying inflammatory process that is having a flare, which clearly is evident with the AKI, with the thrombocytosis, with this patient having progressive shortness of breath, and this potential arthralgia. Does that help,
Right.
Vinny?
Yeah, sure. Perfect. Thank you. So for the next aliquot, a CT scan was performed, which revealed a multifocal mass-like consolidation with early cavitation, suspicious of an atypical infection such as a fungal pathogen such as blastomycosis was noted, and heterogeneous enhancement of spleen, which suggests disseminated involvement. Kidney findings, we have findings compatible with acute tubular necrosis or disseminated fungal involvement. The liver findings, we have multiple hypo-attenuating lesions that could represent cysts or disseminated fungal involvement. And then the pulmonology was consulted, and they suggested no malignant aspects in the lung masses. And a transbronchial biopsy revealed granulomatosis and inflammation with necrosis. And cultures for fungal and mycobacterial organisms were negative. The patient conditions worsened with decompensated respiratory symptoms the day after the bronchoscopy, and a repeated chest x-ray showed deterioration, and a second bronchoscopy revealed diffuse alveolar hemorrhage. And the next aliquot, I will review the final diagnosis. Okay?
So, yeah, another major finding. I guess I'll start digging at this, but I think it does support our initial hypothesis that is the lung so the sequence of events, is the lung what it instigated this and the kidney suffered after? Is it truly a pulmonary renal process? And here there appears to be a massive infection, and they're stating that there's a fungal-like features of this. So we got to be careful because there's many different kind of infections that could mimic a fungal phenotype in the lung. So granulomatous inflammation with necrosis on bronchoscopy. So you can immediately, if you think about non-caseating granulomatous disease, that's sarcoidosis, so you can take that out of the picture, then it leaves the door open to everything else. This patient is immunocompromised, so you have to sort of think about what kind of fungal infections we've had on CPS VMR nocardia present sort of like this. Although GPA can present with lung nodule findings as multifocal nodular infiltrates, but then you also have to worry about cryptococcal, you have to worry about aspergillosis, you have to at this point blastomycosis, histoplasmosis. So at this point, I'm not sure which infection, although histoplasmosis typically is in the Midwest, and could present with broncholithiasis and cavitations like this and so on. But you have to wonder which one of these infections could also take a hit on the kidney as well. So at this point, I'm lacking that information. Maybe you could shed light on that. But I think I would start with, so we have this, the biopsy, and I guess the pathology will reveal the answer. I was kind of wondering if there was a beta-D-glucan, galactomannan, could that also help us to support other, I guess when you're on steroids, I'm not sure if this happened when on steroids, but it could have made it worse. So PJP can flare up with steroids as well. So you have to be careful. When a patient's on long-term steroids, you need to give them prophylaxis. Anything else, Jas?
Oh boy, Vinny dropped like such a big hammer in that last aliquot. So I'm grinning because I've gotten both Reza and Robbie with my own blasto cases, and I feel like um, I may end up being the victim today. But however, I want to pause and say I find it unusual that patient had. First of all, I was actually pretty impressed that the radiologist kind of commented this could be blasto. Usually they're usually like, atelectasis versus pneumonia. But no, so the fact that they were very specific in the readings was actually pretty interesting. However, it doesn't, I wonder without any bony pain, like I know she had these arthralgias, so I would be very, very curious to see if she had any lytic lesions. That doesn't mean blastoid is not possible. Also, without any skin findings. Also, the kidney function. I still think what explains the glomerulonephritis? That is something that is obvious based off the urine studies. Now, some fungal infections can lead to some kidney involvement, but I honestly haven't seen it myself. With the splenomegaly, sure, blasto can do it, but histo comes more to my mind than anything. I still am not convinced this is not vasculitis, or the vasculitis to be, especially your granulomatous polyangiitis can present with granulomas, and that's what we found on the biopsy. And I think that if I would be curious if this. I know I understand this patient's from the Midwest, so their blasto is pretty common. Histo I think is common as well. Not really coxy. I would definitely send out the fungal studies and see if it grows anything. But if not, I still am not convinced that unless it grows something, I think I would probably lean more towards GPA or some type of vasculitis because to my knowledge, and Robbie, you're way more experienced than I am. Have you seen an endemic mycosis leading to diffuse alveolar hemorrhage in this fashion?
I guess if it's like aspergillosis, if it's angioinvasive, you could have. So there's always the propensity to have that. But just go rolling back. This radiologist suspicion of a fungal infection, that could be a red herring. So we have to still explore the possibilities. And like you mentioned, GPA, I do think that's in the running, and we do need the anchors. And Vinicius has yet to kind of bring out the anchor and tell us maybe it's hiding it for the next aliquot. But it's interesting when you look at the pulmonary renal syndrome, the schema on CPS, and if you look at the different compartments where you can get infection, it's rare. Or get a pulmonary renal an infection causing pulmonary renal syndrome usually attacks, or fungal infections attack, the interstitium. And here we still also don't know if the interstitium is evolved or not. So TB, endemic mycosis, and brucella on that schema are things that could potentially cause something like this. So TB, we haven't gotten an AFB, we haven't gotten a quantiferon, so that's something else that Vinicius could just very well show us his cards in the next aliquot. So we still have to think about that as well. So I wouldn't just think about fungal. I would think about TB as well in this case.
Yeah.
Right.
Yeah. Thanks.
Okay, so I'll give you the anchors, Ravi. So the final aliquot, the subsequent testing showed a positive PR3 ANCA, and finally a renal biopsy demonstrated necrotizing vasculitis and acute tubular necrosis with no immune complex deposition on immunofluorescence or electron microscopy. There was an absence of staining for IgD, IgA, IgM, C1q, and C3. So that the final diagnosis is granulomatosis with polyangiitis. Okay, I'll leave you two guys comment.
Wow. Yeah, I think Jas, the walkthrough of nephritic syndrome that you did, posse immune, the GBM, and then the immune complex pretty much gave us where we should concentrate, the area where we should concentrate. And it was a pulmonary renal syndrome. But I think I would approach this in the way you did. And I think it was difficult to really ascertain that this was that. And again, this shows you be very suspicious of the reading that's given, because that blastomycosis could just have you or send you down this deep rabbit hole, but keep all your options open. And GPA can manifest like an infection in the lung, and it could have all sorts of odd shapes and infiltrates in the lung that could like confuse you. So, very good case there, Vinicius. We had a great walkthrough of pulmonary diseases and also renal diseases. So a lot to learn for everyone here. Thank you.
Yeah, no, I agree, Vinicius. That was like such a great case. Like I'm like literally sweating over here. I a couple of things. I think for me, thank you, Ravi, for your kind words. Honestly, couldn't have done it with like co-discussing with such a great partner. Um, I think for me, what I wasn't so convinced by, and I would love to like see what Vinicius' teaching point was, but the fact that this patient glomerulonephritis wouldn't have explained, at least right off the bat, with a fungal etiology. So that's where I was just kind of felt that it did not completely um, kind of fit the picture of an endemic mycosis. But it's one of those things where these things can always sneak up on you. So thank you, Vinny, for bringing this case. Any teaching points before we get the wonderful Parisa to do her teaching points?
Yeah, I'll just comment something. Just to thank Noah that will take the primary care of this patient and helping me with the case. And meanwhile, I was studying the diagnosis and management of ANCA-associated vasculitis. And sure, so the basic main point that we need to take in account, like in granulomatosis, polyangiitis, microscopic polyangiitis, and a third disease that is studied separately, that it is the eosinophilic granulomatosis with polyangiitis. And so the directed target of ANCA is primarily like neutrophils and the activation of the complement cascade. And the most affected organs are lung, kidney, and ear, nose, throat, and skin. And the diagnosis for these ANCA vasculitis, so the microscopic polyangiitis and the GP, are basically did with biopsy and the ANCA. And the biopsy, you need to differentiate between some other necrotizing glomerulonephritis, such as um, from cocaine abuse. And when you do the respiratory biopsy, it is important to differentiate in the granulomas from the sarcoid granulomas. And basically, the P-ANCA is more corresponds to the myeloperoxidase ANCA, and the C-ANCA will corresponds more to the PR3 ANCA. So that's the main point, differentiating between the ANCA vasculitis. And basically, the treatment is in the acute phase is steroids, prednisone, and cyclophosphamide if the patient does not respond to it. And for the maintenance phase, you can give like rituximab, and then that's a good alternative to treat. And the third disease, that is the eosinophilic granulomatosis with polyangiitis, has a more eosinophilic component. So in the majority part of the patients, almost 100% of the patients will present with asthma. And you have like different stages of the disease. You have the vasculitic phase and the eosinophilic phase. And another point and another table that we can have is that the eGPA can be both ANCA positive and ANCA negative. So there is also a possibility to an overlapping of the clinical features of the clinical manifestations between the ANCA and non-ANCA. And so that's it. Thank you for the case, and go ahead, Parisa.
Thank you, everyone. It was a phenomenal case and phenomenal discussion. We started with a patient who presented with shortness of breath, cough, and which has the subacute time frame. And we discussed that we need to think about common presentation first, like pneumonia, and take a chest X-ray. We need to think about vasculitis and interstitial lung disease in the background. And we also think that usually cough symptom localize all the presentation to the lung. And we learned that stridor is the presentation for upper airway disease, while wheezing is the things we are usually observing in bronchial asthma. We talked that crackles is a presentation happening when we are having alveoli involvement, when the alveoli are filled with water and pus, or when the fibrosis is happening. We talk about that one of the diagnostic feature in the PMR is the rapid resolution of the symptom, including stiffness and weakness with the longer steroid treatment, more than 12 weeks. And we also talked that one of the other criteria for the PMR is that ESR is elevated more than CRP and the CK is normal, while for myositis and steroid-induced myositis, the CK it's not usually normal. We talked that arthralgia, when we're having arthralgia in this patient, usually we less likely think about PMR because it is less likely for this group of patients to have PMR. They're usually symmetrical arthralgia guiding us through lupus mainly. And if we have the past medical history or of the Midwest, when patient is coming from Midwest, we are thinking about tick-borne disease as well. We talk about Asia syndrome, which is a PMR presentation, which is happening in patient after COVID vaccination. We talk about teen appearing presentation. We are thinking about cachectic process when it is happening longer than 2 months specifically. We are also thinking about inflammatory process. And we also think that when somebody is presenting with ascending weakness, we need to think about requiring for airway protection. We also learned about the Leiden-Wiedermeyer syndrome, which is happening in the older middle-aged female with cough. It is a Mycobacterium avium infection. We talk about different causes of the leukocytes. It could be infection, steroid, and necrosis. We talk about Thales pneumonic, which covers thalassemia, anemia due to chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. We talk to how to approach AKI. We are usually doing Foley challenges to see how the creatinine is changing. When it is improving, maybe it is a ATN due to sepsis, and also a specific gravity could help us in this case. But when patients having low complement level, we are thinking about lupus, MPGN, and ANCA-related vasculitis, all of them. And also are not RA itself, but complication of the RA like cryoglobulinemia. But when the complement are normal, we are less likely thinking about vascular-related causes. We also talk about how we need to approach thrombocytosis. They could be subacute to chronic inflammation. And when they are reactive, we are thinking about autoimmune causes, again, associated vasculitis, dermatomyositis, and polymyositis. We thought that IgG4 disease is typically indolent, and we require tissue for diagnosis these kind of diseases. We talk about C3GM, which is C3 deposition in the kidney without significant immunocomplex deposition. We also talk that when patient having protein creatinine ratio more than 3 gallon, we are thinking about nephrotic syndrome, and we need to rule out melanoma by assessing the level of light heavy chain levels. We also investigate ECR and CRP, although both are chronic inflammatory process markers, but ECR might be elevated in autoimmune condition and malignant condition, while CRP might be more specific to bacterial infections. We have a granulomatous pattern in the lung for this patient. We talk that when non-caseating granulomatosis is happening, we are thinking about sarcoidosis, but in immunocompromised patient, we need to rule out fungal infections, including nocardia. When multifocal granulomatosis are happening, we need to rule out all the fungal infection, aspergillosis, histoplasma, blastomycosis, which might happening with splenomegalia, and the GPA, it should be in our list, like this patient happened in here. We talk about different pulmonary renal syndrome infections, including TB and brucella. We also learned that GPA could manifest like lung infection, and when we have granulomatosis plus glomerulonephritis, we need to click for GPA, and GPA could be ANCA positive and ANCA negative. Thank you so much.
Teresa, that was remarkable. I hope people here listen to your teaching points and get an idea how professorial you are in purveying your teaching points like a lecture. So appreciate the fabulous teaching points. Thank you, Jas, for coming in. Late VMR, but are you working?
Yeah, I am. So this worked out perfectly.
All right, great. Yeah, so this time worked out great. So thank you, everybody. Take care. See you, Jas. See you, everybody.
Bye, everyone.